Today on Newsday.
All of a sudden, we move a couple of percentage points on obesity because there's been some movement around weight loss. That's pretty exciting from a healthcare delivery standpoint.
My name is Bill Russell. I'm a former CIO for a 16-hospital system and creator of This Week Health, where we are dedicated to transforming healthcare one connection at a time. Newsday discusses the breaking news in healthcare with industry experts, and we want to give a big thanks to our Newsday partners, ClearSense, SureTest, Tossite, Order, Healthlink Advisors, Cedars, Sinai, Rackspace, CrowdStrike, and Fortified Health. Now, let's jump right in. All right, it's Newsday, and Lindsey Jarrell is in the house, CEO, Healthlink Advisors. Lindsey, welcome back to the show.
Yeah, thanks, Bill. Good to be here.
I'm looking forward to this. There's a lot of things going on in healthcare. As always, love to get your take on some of these things and just go back and forth a little bit. There's been a lot of talk about Walmart pulling out of healthcare and what that means. And they're not the only ones. We had Walgreens pull back significantly. And I guess I'm just wondering when Amazon is going to pull back significantly. What are your thoughts on the Walmart pullout?
Yeah, it's fascinating to watch these big retail companies enter healthcare and then pull back. I think we've seen it over and over again. Very close to where I live, in the same little town I live in, there's a Walmart supercenter, and I saw them build probably 30,000 square feet of dedicated clinic space in their parking lot. And I think it opened maybe 3 months ago. And now I know that's for sale through some other connections I have. That building on Walmart parking lot is for lease. They're looking to sell that clinic business since they've decided to shut down. And I just think they don't appreciate how complex healthcare is and the margins that we have to operate at, right? I know last year when the federal government released changes to the Medicare Advantage, to the MA plans, which is a lot of what I think Walmart was dependent on, took a lot of profit out of how people were making money. So I think it's going to continue. The Walgreens, you mentioned that as well. We'd actually started using that Walgreens Village Medical for one of our family members, and then just got the letter and said, we're shutting it down, move your medical records, right? I think people deserve a lot better than that. And all of these companies entering the space and exiting is not good ultimately for the patients, I don't think, especially when they're like eroding away patients from the big care providers that stay here year in and year out. In our town, that's Baycare Health System and Tampa General and Adventist. Those are the folks that are going to be here while these other ones come and go. So I'm pretty disappointed by it and just wish it wouldn't be happening so much.
I remember having a conversation with CFO once, and he said, we only make money, this is a large health system, we only make money in 4 areas. I'm like, you're kidding me now. And I think it was imaging, surgery, cancer, orthopedics. I forget, I'm going to miss something there, but essentially that was essentially it. And I said, what about primary care? He goes, oh, no, we don't make money on primary care. That's what feeds those other things. And I was like, then when I see these retail strategies, I don't understand how they work. Unless you're a payer, I guess they work because you're getting that money up front. But if you don't have those back end things, how do you make primary care work? And will we be seeing Amazon make that same move, I guess?
And I remember another time when you and I were chatting, you mentioned the pharmaceutical angle to it, right? If Walmart captures the patients, they have that catchment area of primary care and bring them in, and they can direct all those patients to their pharmacy. Does that make enough of a difference to capture the margin to keep the business open? Apparently not, right? It's a wonder why they stay in that space. But of course, they're going to stay in the pharmaceutical space because there is real margin there. I think it's just in the care provision. I do know, based on what we've been hearing here, again, locally, that these Walmart clinics are being offered up to payer organizations. As you mentioned, the payers are getting in the primary care business. I know the payers are looking actively to buy those primary care clinics. That makes sense to me, right? Because especially if you're controlling the back end of that at-risk life and you're in the care delivery business, that's almost an unfair advantage to the big providers in some way.
It used to be big tech and retail, and then there was the traditional providers, and there was the payers, and now it seems to be becoming more and more of a two-horse race. I remember, so St. Joe's, we had almost 35-40% market share in Orange County, California, and we partnered with CVS. So when you went into a CVS Minute Clinic, it was us. We were there. Our EHR was there. We were there. That's what we did. And then it seemed like CVS said, no, we can do this ourselves. But from what I hear you saying, it seems like we're going back to the future where they're essentially saying, look, we have this space. There is value to bring these people in here. You get immediate fills of the pharmacy. You get unfortunately get people buying bags of chips and soda and other things. So there's still value. They may go back to the payers and providers to say, hey, can you put people in here?
I think those partnerships for the retail side is going to be the way it's going to go. That's what I see. And you're dead on with the chips, right? This is a bit of a tangent, but Walgreens almost made their number last quarter because of a mango flavored candy that went viral on TikTok, not because people suddenly want to go to Walgreens. That was just their branded candy. And so that's where they're going to make their margin, right? And so I think those key partnerships are the way it's going to work. They need to stay out of the direct delivery business. So I don't think they have the patient at heart. So.
It's interesting. And some of them are payers, right? So CVS is a payer. Now, we'll see how this plays out. We were talking earlier before we hit record, which always happens. And there's a couple stories out here on these GLP-1s, these weight loss drugs that are out there. And I wanted to touch on that a little bit with you. They're springing up everywhere. Will this have an impact on healthcare providers long term?
I've been watching this space pretty closely for a long time. I've had a passion in what over the last 20 years, why the advent of chronic disease, right? And so when I get a little bit of time, I have a personal passion around what's causing that. And I'll tread carefully here, but I think a lot of it has to do with our food production and quality of food that we introduce into our lives here from big agra and big food. But these GLP-1 meds can move that curve, right? And cause people to just not eat as much. And so without talking too much about the med, I know they're exploding, right? There are telehealth companies popping up everywhere saying we can get you on these weight loss meds. I actually nerded out a little bit and listened into quarterly earnings call the other day, a few weeks ago, right? And when you look at their trail of what meds are in clinical trials coming up, it's all variations of those meds for different diagnoses and diseases. And they said 150,000 new prescriptions are being written per week for their meds, and that's just with one pharmaceutical company. So when I look at that and think, let's assume the meds are safe, they've been through all the trials. When we look 3 years down the road and all of a sudden we move a couple of percentage points, hopefully, on obesity or on diabetes or on heart disease, because there's been some movement around this weight loss at large scale numbers, that's pretty exciting from a healthcare delivery standpoint in terms of health of a population, I think. I'm optimistic about it. I just wonder how much money that's going to take out of the system if people are healthier, because right now it's just going up and up when we think about the impact of diabetes and obesity and heart disease and chronic conditions that follow. I'm optimistic about it. I'm fascinated by it. I'm watching it closely. I wonder what kind of impact that's going to make on some of our healthcare providers.
This has been the age-old problem. Are we healthcare or are we sick care? And when we become healthcare, when we really become health, and a lot of health systems went out and rebranded as blah, blah, blah health, blah, blah, blah health. So we are about health. But the reality is, under fee-for-service and some of these other models that exist, if we are successful on the health side, we do stuff on the other side. And the thing is, that money isn't coming into health care providers. That money's going to pharma. And so you could see a significant hit on the balance sheet side. By the way, I agree with you 1,000%. Man, a couple of percentage points. I believe the amount of sugar we intake is just astronomical. The advertising business, it all works against you. You walk into a store. I remember reading a diet book once. It's just shop around the outside, because if you shop on the inside, it's all stuff you shouldn't eat. I'm like,
right.
It's every aisle is loaded with stuff. And you're like, wow. So it conspires against us. So let's assume everybody starts to, and it's not everybody. I'm going to touch on that in a minute. But I know that just going to dinner the other night, there's 10 people at dinner and 2 of the people at the table were taking GLP-1s. And I thought, I wonder if there's another 1 or 2 people that just isn't saying they're taking GLP-1s. And is that the percentage? Are we starting to see that kind of percentage? With that being said, I think the lowest cost you can get a GLP-1 is like $500 a month. And on average, they're right around $1,000 a month. And a majority of the plans don't cover them today, which is another conversation to really look at as we move forward. That's an expensive proposition to get your weight under control, and probably indicative of the fact that we haven't been able to get our weight under control.
Yeah, you're right. Access is going to be a huge problem. I know different payers are approving the drugs for different conditions, right? So if you have uncontrolled blood sugar or different thing and obesity, it's easier to get approved than otherwise. But a friend of mine is investing in a compound pharmacy And that's part of their business model because apparently compound pharmacies can make the drugs because they're on the FDA shortage list. And so it's actually part of the business model there. And with them, it's only $400 a month, but still, I know there's lots of people who can't afford $30 a month. So there's definitely an unfair advantage there for folks who can afford it.
We'll see if that changes, and we'll see what kind of discussion or conversation we have. Will the pharmaceuticals try to target that lower price point, or will it just naturally, the way pharmaceuticals work is essentially it works down over time until it becomes a generic, I guess.
It'll take a long time, I'm afraid, though. They're making a lot of good margin at the upper end based on the quarterly numbers that are hitting the street.
Yeah. All right, let me give you this one. So Ascension, the Beckers wrote an article, Ascension is praised for their response to this outage. And really what they focused in on was the transparency. They're putting things out on their website, they're communicating and all those other things. And I think for the most part, a lot of it is still down today. And this has been the better part of a couple of weeks. When you're looking at, if you were going to write an article about, hey, their response was good, is that the only metric you'd look at as transparency? I know it's a good metric from, we want them to be more transparent, as Change Healthcare potentially wasn't as transparent and whatnot. But, is there something else we should be, it feels like getting back online would be the metric. Did they respond well? It's been 2 weeks and people are still being turned away. I'm not sure I would have written that article.
Yeah, and back online with what systems, right? I think there's a lot of focus right now, and I don't dare touch this too much without Drex in the room because I'm not an expert like he is, but with what systems, there's so much focus right now on we need to bring the systems we had back. And I think there's a lot of good business continuity planning that could be going on that says, how do we get back into a service mode regardless of the system we were just on so that we can recover and start to provide care? Easier said than done, but I think there's a lot of business continuity planning that needs to change in our industry and across industry for this ransomware cyber style attack. So I'm with you. I think it's how fast can we return to service and what kind of plans do we have in place is a really good metric. That article reminded me a little bit going way back. Remember the Tylenol and the cyanide, right? And they were praised for their transparency there and saving lives. It ultimately did have a big effect on safety and communication and how you communicate to consumers with safety recalls. I was thinking about that when I was reading that article. I was wondering, what will this change, right? So if Ascension's praise, good for them, but what will it change about how these things are communicated out and what patterns will we see emerge? I don't know. It's going to be interesting to track that one.
Our beloved keynote show has moved to Thursdays. Catch every episode weekly on our This Week Health conference channel. Don't miss conversations with top health system leaders designed to transform healthcare one connection at a time. Subscribe to This Week Health Conference and stay updated every Thursday. I'll let Drex handle those kinds of conversations. I'll get us back on large language models. ChatGPT 4.0, as in O, the letter O, came out last week. And O meaning omni, so it can now hear, it can now see. It's bringing all of those senses into the mix. That's how they came up with 4.0. Came out. It's interesting from a marketing standpoint to watch because they came out with 4.0 like the day before Google did, I don't know, like 50 announcements. And if you look at the news cycle, I think they just completely swamped Google's announcements. Not that they're not relevant, but from a marketing standpoint, it was pretty amazing. When you're talking to healthcare leaders and you're exploring what's going to have an impact on healthcare, I'm hearing more and more that there's a belief that, hey, short term, we're maybe overestimating this, but long term, we're not giving this enough credence. This is really going to change the game.
I agree with that. I don't know if most folks realize that yet, but the ones who are thinking about it, that's what I'm hearing as well. Without saying specifics, in the ambient listening space, right? We're listening in on a visit and doing documentation, clinical documentation, and creating a note, right? That felt like that was bleeding edge 4 or 5 years ago. I can remember watching the first demos of it. Now, a bunch of vendors are selling it. There's a couple of vendors who are selling it at a very high price. That's going to be commoditized in the next 24 to 36 months with the power of these large language models. And when it's commoditized, the price is going to drop. So I think that's going to be better for safety. It's going to be more affordable for the provider. And that's just one simple example of where we've got some vendors really trying to capitalize on that right now. So I think we're going to just see commoditization of different things where there's a lot of special IP around it right now. These models and are going to allow us to just commoditize more to drive cost out of the system. As long as it's safe, I'm all for it. I think about the percentage of a healthcare system's budget that's spent on software maintenance and subscriptions today. Hey, and I'm ex-CIO. I've made a living in this business. I'm pretty discouraged by it because it's taken a whole lot of money out of care delivery, and I want us to have the ability to drive that cost down some more.
That is the one thing that is getting very little press at this point, but it's starting to get some press, which is we have this mantra of go to platforms, which is great. I've heard recently from some CIOs that some of the platforms have really dramatically increased their pricing. And it's not that they're not offering additional services. They're essentially saying, look, our platform can do all these things. Instead of piecemealing it now, you have to buy the whole platform. And therefore the price is X or Y. And so we're going to these platforms. These platforms are a lot harder to migrate from, so that the transition cost is prohibitive. It's almost like they know they've got you. Is there a better approach or a better solution? We've gone best of breed. That has all sorts of issues with it. We've gone platform, and now we have lock-in and those kinds of things. Is there something in between, or is it just each case is unique?
Yeah, I don't know there's a better answer right now, but I think we do a lot of system selection work. There's two major vendors. I'll say not in the core EHR space, just trying to be fair, where we have literally side-by-side proposals. One vendor's increased their pricing 28% the last 20 months. Another vendor's increased their pricing 31% over the last 24 months. Very clear examples, same scale, same product, same platform. And so they're taking advantage of the market to drive margin. I think we got to be smart about that and use competition to try to drive that down as much as you can. I don't know there's a better kind of best of breed or niche approach right now, because some of the platforms in some of the areas do offer an advantage. And we're seeing a lot of that in imaging right now. Imaging has very much been a best of breed environment outside your core packs for the last 8 years. Now there's big platform companies coming to play, and you get better performance, better productivity, better diagnostic quality. So it's hard to argue against that, but you still got to be smart and use competition to drive the price down.
Are we building out good ROI models, and do we go back and measure those ROI models as CIOs and as health systems?
No and no.
That's it. That's what I feel like too. And it's one of those things, I don't know if it's an opportunity for someone to come in and help, or if it's something that's a discipline that we just need to get better at. It's like we're moving so fast, like once we get it done, we're not going to go back and look at it. We just use it for approval.
And we could take this conversation immediately to governance, right? To say, how do we build that? And I didn't mean to be crass, but the answer is no. We do a ton of TCO models. We've built a brand around that in the business, and just a good financial understanding of financial discipline in IT. We need more of it, that's for sure.
Lindsey, always great to catch up. Stay cool.
Thanks, Bill.
Thanks for listening to Newsday. There's a lot happening in our industry, and while Newsday covers interesting stuff, another way to stay informed is by subscribing to our daily insights email, which delivers expertly curated health IT news straight to your inbox. Sign up at thisweekhealth.com/news. Big thanks to our Newsday sponsors and partners: ClearSense, SureTest, Tossite, Order, Healthlink Advisors, Cedars Sinai, Rackspace, CrowdStrike, and Fortified Health. You can learn more about these great partners at thisweekhealth.com/partners. Thanks for listening. That's all for now.